think I could have it anyway.
told me not to trust the
Having
healthcare
treatment made me
professionals.
feel
I thought they were going to
I
make
went
me
to a
really
health
fat.
I felt like someone else might die
People
because
with
I
eating
was
disorders
made
are
to
very
run.
sensitive
I
and
nearly
very
said
volatile.
I've been
something,
to various
but
people.
the health
Putting trust into
professionals
healthcare
listened to me.
professionals
Do you think
means
So neither did
that
I.
I had to relinquish
didn't
I
know
felt
what
too
was
fat
going
to
on.
ask for help.
But
This
now
is
I
very
think it's a
difficult
really
for
I
me.
had
obvious thing
anorexia
to
nervosa
ask
for 4
someone.
years before it was diagnosed.
I sought help because I missed my periods. They told me to come back when I'd missed them for 6 to 12 months. When I went back, they just put me on the pill. I went to another healthcare professional, but she said, "Oh, just eat a little bit more and you'll be okay." Can't you just eat a bit more? Can't you eat a biscuit and have a bit of cake every day? And sent me away. I understand now, but at the time I was like, no, I can't. Or, yeah, all right, I'll do that. And not do it. Because it wasn't just about going and having a piece of cake, because there was lots of emotions tied up in the reasons why I wasn't eating. So I found she was quite ignorant about it. I could lie to her. I could fob her off because she didn't really know anything. She had crap weighing scales. It was only when someone else phoned her on my behalf and complained that she took me seriously. I think she could have been trained better, and I think she realised that as well. More awareness of anorexia nervosa is needed in the healthcare service. I expected to be met by people who were trained regarding eating disorders. Healthcare professionals should be better educated about how to deal with them.
I first went to see a healthcare professional when I was 17, and I told her I was jealous of anorexic people. She said I was attention seeking. I didn't go to get help for another 2 years about that. I understood what she meant, that I was probably trying to seek help, but at the time the comments upset me. I tried to seek help after that, but I didn't think I could ask. I went to a healthcare professional after it came up on the screen underweight. I nearly said something, but the healthcare professional didn't mention it, so neither did I. I felt too fat to ask for help. I had anorexia nervosa for 4 years before it was diagnosed.
I went to see a healthcare professional and they told me to go away, eat 3 meals a day and you'll be fine. The healthcare professional I saw was too unhelpful, but I felt too fat to ask for help. I lost faith in the health service. I wanted to feel like I could trust a health professional, to receive help and encouragement. I expected help. I expected to be cured. Someone who doesn't understand eating disorders can make you feel unsafe, because you might not be able to tell them the truth. The service needs more people who know about eating disorders. Healthcare professionals who didn't know about eating disorders would say things like, "Oh, come on, everyone worries about what they look like." I felt like there was a general feeling of irritation towards me. I know they were trying to help me, but I thought they were going to make me fat.
A healthcare professional was taking blood from me and she couldn't find a vein. She asked me if I'd eaten anything that day and then proceeded to talk about when she was ill and really thin.
Eating disorders can be severe and enduring mental illnesses that can have serious physical, psychological and social consequences. Anorexia nervosa has the highest mortality rate of any psychiatric illness through suicide and direct physical effects. Additionally, patients who suffer with an eating disorder are also very likely to suffer with other mental health problems or disorders.
Nurses play an important role in the early detection, assessment and treatment. A framework for Wales has been written by the Welsh Assembly Government for eating disorders. The framework highlights that there are major weaknesses and gaps across Wales which can result in individuals not receiving the care their condition requires. The framework explicitly reinforces the role of primary care teams, generic psychiatric and physical health services in identifying, assessing and intervening with people who have an eating disorder. This means that at all levels, healthcare professionals have a responsibility to be aware of anorexia nervosa. They must also have the ability to assess and refer cases if necessary. Recently, the Welsh Assembly Government committed funding to improve the current health service for eating disorders in Wales. Therefore, a commitment towards better identification, treatment and outcome for patients with anorexia nervosa has been made. On a personal level, you are taught that you should adopt the 6 core values. These are known as the 6 C's. These enduring values and behaviours underpin compassion in practice. They include care, compassion, competence, communication, courage and commitment. Therefore, it is imperative that you become more aware about anorexia nervosa in order to be able to provide appropriate care to patients that may present with symptoms of the disorder. Caring defines us and our work. People who are receiving care expect it to be right consistently throughout every stage of their life.
Funding was a problem. I didn't feel worthy of help, and I didn't think I could have any anyway. Having treatment made me feel guilty, because I felt like someone else might die because I was receiving their treatment.
I felt privileged to receive any kind of treatment.
Patients often report feeling as though they don't deserve treatment. In order to care for our patients, we should foster an environment where patients have realistic expectations regarding treatment and that those expectations are met. Compassion is how care is given through relationships based on respect, dignity and empathy. It can also be described as intelligent kindness and is central to how people perceive their care.
Healthcare professionals who were approachable and friendly were better. Some healthcare professionals were scary and intimidating.
Treatment was frightening because my control was taken away. I did trust some of the healthcare professionals in the service. The healthcare professionals that were really good used to let me take all the time I needed for my appointments. They would let me just sit there for 40 minutes and cry if I needed to.
Now that we are aware that this is how patients feel, we are able to be compassionate about their disorder and their treatment experience. Competence means that all those in caring roles must have the ability to understand an individual's health and social needs, and the expertise, clinical and technical knowledge to deliver the effective care and treatment.
The healthcare professional was knowledgeable and referred me when I needed to be referred. I thought she was professional.
I wanted to feel like I could trust the healthcare professionals to receive advice and encouragement. The healthcare professional I felt comfortable with was knowledgeable and helpful. She didn't force me to do anything I didn't want to do.
I trusted healthcare professionals with more knowledge.
Having the willingness to discuss a disorder with a patient may only be useful if you have an awareness of the disorder from a clinical perspective.
Some of the healthcare professionals felt like they had to have their 2 cents, because everyone has something to say to me. Because just like, are you saying this from the position of a doctor or a nurse? Or as someone who just wants to say, oh well, this is what I think you should do. And that's quite weird. So personal. You get confused. Education is the most important thing.
Someone who was persistent and gave a sense that she knew what she was doing. She wouldn't let things escalate. I didn't feel like I could get away with not complying, and so I trusted her, something I don't do easily.
Recovery involves a collaborative effort between the individual and the healthcare professionals. It requires sufficient motivation to change and adequate support and guidance. The healthcare professional needs to understand the patient's dilemmas and ambivalent feelings whilst promoting the possibility of change and recovery. Communication is central to successful caring relationships and to effective team working. Listening is as important as what we say and do, and is essential for no decision about me without me.
The good healthcare professionals are the ones that listen and know what they're doing. They do their job as it needs to be done. I prefer healthcare professionals who are willing to compromise, not necessarily about getting better, but about getting no worse. Someone who was prepared to talk in my language.
Communication is the key to a good workplace and benefits staff and patients alike. Courage enables us to do the right thing for the people we care for, to speak up when we have concerns, and to have the personal strength and vision to innovate and to embrace new ways of working. This includes being confident in using brief tools to assess whether a patient has an eating disorder.
I've been to various people and not one of them said, "Do you think you're eating enough?" I just didn't know what was going on, but now I think it's a really obvious thing. You should ask someone. I felt a bit neglected, I guess.
Your awareness of anorexia nervosa will result in increased confidence and courage to be able to detect, assess, and refer the patient to the appropriate services. A commitment to our patients and populations is a cornerstone of what we do. We need to build on our commitment to improve the care and experience of our patients, to take action and make the vision and strategy a reality for all, and to meet the health and social care challenges ahead.
Research suggests that by learning more about anorexia nervosa, you will be more able to detect, assess, and refer patients who may have the disorder.
This will benefit the patients by providing early intervention. Early intervention will improve the clinical outcome for many people who have an eating disorder, and studies demonstrate that prognosis is better with early intervention. The patient is more likely to trust you if you are aware of the characteristics of the disorder. This means you are more likely to develop a therapeutic alliance with the patient.
This also contributes to a more positive prognosis for the patient throughout their treatment. You will know that you are working from evidence-based practice by providing this care.
You will be contributing to a positive change in treatment experience for patients who have anorexia nervosa.
Your goal could be to have better awareness of the disorder when caring for patients in the future. The following information has been summarised from the current Diagnostic and Statistical Manual for Mental Disorders and the International Classification of Diseases.
Anorexia nervosa is a serious mental health condition that may develop into an enduring mental disorder that requires the appropriate responses from healthcare providers. Anorexia has the highest mortality rate of any psychiatric illness through suicide and direct physical effects. Additionally, patients who suffer with eating disorders are very likely to suffer from other mental health conditions or disorders. There are 3 essential features of anorexia nervosa: persistent energy intake restriction, intense fear of gaining weight or of becoming fat, or persistent behaviour that interferes with weight gain, and a disturbance in self-perceived weight or shape.
The individual maintains a body weight that is below a minimally normal level for age, sex, developmental trajectory, and physical health.
There are 2 subtypes of anorexia nervosa. The first is the restricting type. During the last 3 months, the individual has not engaged in binge eating and purging behaviours. This subtype describes presentations in which weight loss is primarily achieved through dieting, fasting, and/or excessive exercise.
The second subtype of anorexia nervosa is the binge purging type. During the last 3 months, the individual has engaged in recurrent episodes of binge eating or purging behaviour such as self-induced vomiting or the misuse of laxatives, diuretics or enemas. Some individuals with this subtype of anorexia nervosa do not binge eat but do regularly purge after the consumption of small amounts of food. The severity of the disorder can be assessed for adults using the Body Mass Index or BMI. The ranges are from the World Health Organization categories for thinness in adults. The level of severity may be increased to reflect clinical symptoms, the degree of functional disability, and the need for supervision.
Individuals with this disorder typically display an intense fear of gaining weight or of becoming fat.
This intense fear of becoming fat is usually not alleviated by weight loss. In fact, concern about weight gain may increase even as weight falls. Younger individuals with anorexia nervosa, as well as some adults, may not recognise or acknowledge a fear of weight gain. The experience and significance of body weight and shape are distorted in these individuals. Some individuals feel globally overweight, others realise that they are thin, but they're still concerned with certain body parts.
The patient will often view their weight loss as an impressive achievement and a sign of extraordinary self-discipline, whereas weight gain is perceived as an unacceptable failure of self-control.
Often the individual is brought to professional attention by family members after marked weight loss or failure to make expected weight gains. If the individuals seek help on their own, it is usually because of distress over the somatic and psychological effects of starvation. It is rare for an individual with anorexia to complain of weight loss per se. In fact, individuals with anorexia nervosa frequently either lack insight into or deny the problem.
The semi-starvation of anorexia nervosa and the purging behaviour sometimes associated with the disorder can result in significant and potentially life-threatening medical conditions.
Physiological disturbances, including amenorrhea and vital sign abnormalities, are common. While most of the physiological disturbances associated with malnutrition are reversible with nutritional rehabilitation, some, including loss of bone mineral density, are often not completely reversible. However, some individuals with anorexia nervosa exhibit no laboratory abnormalities. When seriously underweight, many individuals with anorexia nervosa have depressive signs and symptoms, such as a depressed mood, social withdrawal, irritability and insomnia, and a diminished interest in sex. Obsessive-compulsive features, both related and unrelated to food, are often prominent. Most individuals with anorexia nervosa are preoccupied with thoughts of food. Some collect recipes or hoard food. Observations of behaviours associated with other forms of starvation suggest that obsessions and compulsions related to food may be exacerbated by undernutrition. When individuals with anorexia exhibit obsessions and compulsions that are not related to food, body shape or weight, an additional diagnosis of obsessive-compulsive disorder or OCD may be warranted. Compared with individuals with anorexia nervosa restricting type, those with binge eating or purging type have higher rates of impulsivity and are more likely to abuse alcohol and other drugs. A subgroup of individuals with anorexia nervosa show excessive levels of physical activity. Increases in physical activity often precede the onset of the disorder, and over the course of the disorder, increased activity accelerates the weight loss. Individuals with anorexia nervosa may misuse medications, such as manipulating dosage, in order to achieve weight loss or avoid weight gain. Individuals with diabetes mellitus may omit or reduce insulin doses in order to minimise carbohydrate metabolism. In addition to amenorrhea, there may be complaints of constipation, abdominal pain, cold intolerance, lethargy, and excess energy. Some individuals may have scars or calluses on the dorsal surface of the hand from repeated contact with the teeth during induced vomiting.
Nurses play an important role in the early detection, assessment and treatment of anorexia nervosa. Unfortunately, there is strong evidence that patients who go on to develop very serious eating disorders are likely to have attended generic health services on a number of occasions without their disorder being reported by patients or detected by the healthcare professionals. There is a need, therefore, to develop a greater awareness amongst frontline healthcare professionals of suitable screening tools and to encourage their wider use. Firstly, height and weight can be measured to determine a low or high BMI. Either presentation should trigger you to question the patient regarding attitudes and behaviours relating to weight and body shape. A simple screening tool, known as the SCOFF assessment, can establish whether a referral is required. The SCOFF questions are: do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone in a 3-month period? Do you believe yourself to be fat when others say you are too thin? Would you say that food dominates your life? For this screening questionnaire, you award 1 point for every yes answer that a patient gives. A score of 2 or more indicates a likely case of anorexia nervosa or bulimia. People with anorexia nervosa typically have mixed feelings about change. The prospect of treatment and recovery can feel incredibly frightening. Their behaviours may give a sense of being in control, albeit in an insecure and distressing way. Letting go of an eating disorder can increase fears of loss of control, evoking a deep fear of change. This may result in the patient feeling compelled to withhold information from you or to not tell the truth when you ask them questions. Patients often report experiencing conflicting voices in their head when they are about to seek help for their anorexia nervosa or during their treatment.
The eating disorder voice in my head told me not to trust the healthcare professionals. I thought they were going to make me really fat. People with eating disorders are very sensitive and very volatile. Putting trust into healthcare professionals means that I had to relinquish control. This is something that is very difficult, given the controlling nature of this disorder.
I didn't tell the truth about my anorexia behaviours. I had 2 voices in my head, the eating disorder voice and the well voice. It was hard for me to distinguish between myself and the anorexia.
Early intervention of anorexia nervosa can prevent the condition from escalating. It can also avoid long-term damage and the condition continuing. When people with anorexia nervosa present for the first time in adulthood, the disorder may already be of some years' duration and therefore may require longer periods of intervention and monitoring.
Swift referral will allow for speedy assessments to identify risks and indicate where early intervention or advice on care management could prevent an individual's physical or mental health deteriorating. Your increased awareness of the characteristics of the disorder will enable you to approach the subject with care and compassion. Even though the patient may not be ready to tell you that they are experiencing symptoms of the disorder, their confidence in the health service may be increased as a result of the care that you provide.
If you suspect that one of your patients has anorexia nervosa, you should refer to one of the healthcare professionals within your department. This will depend upon whether you are working within a primary or secondary healthcare team. At first, you should refer to a senior member of staff. This staff member may carry out a diagnostic assessment, or the patient should be referred to psychiatric services. You should also fully document your concerns in the patient file so that communication with other healthcare professionals is achieved. You should always raise your concerns with another healthcare professional to assist in the early intervention and treatment of anorexia nervosa. Anorexia is a serious condition that warrants the awareness of the characteristics of the disorder and the ability to detect and refer cases if necessary. Your increased awareness and confidence of the disorder will mean that you are providing appropriate care for your patients and improving the service for eating disorders across Wales. Thank you for listening. If you would like any further information, please refer to the NICE guidelines, the Eating Disorders Framework for Wales, the International Classification of Diseases, and the current Diagnostic and Statistical Manual of Mental Disorders.